So which is why we have our speaker for the day, Dr. Seetharaman Iyer. He has done his MD from my alma mater, Iyer Hospital, and he's a very well-trained musician and performs very well. So I think this sort of a presentation is going to be a cakewalk for him.
Good evening to one and all present here, and it gives me immense pleasure to present on this niche topic of Endoxifen specifically. And the theme which I'm going to speak today is somehow a little difficult, and I'll tell you why. I have this image which exactly portrays what I'm supposed to do right now. So imagine Endoxifen is getting married to psychiatry. Endoxifen is the bride and psychiatry is a groom. So people have spoken well about how good the bride is, how nicely she works, and there's this one person who's very cynically looking at the bride from a patriarchal society perhaps, and is going to speak about various side effects and bahu ki buraiyan. So let me do that with whatever evidence I have. So some pharmacokinetic aspects, just to make sure that we are in line with the whatever effects Endoxifen is having, and how we can study the pharmacokinetics in that aspect. So initially, if we see that there is a linear increase in the concentration, the linear increase in the concentration is obviously beneficial. Tmax, again, it is 4.5 to 6 hours. Cmax is again 134 mg per ml, and it's plus minus 32, so that's okay. And we have a very good T half. It's around 52 to 58 hours, so T half is excellent. And the most important thing, my very good friend Dr. Shashank spoke about the CYP aspects. He had a query. So CYP metabolism is like not present for Endoxifen. That's the reason drug-drug interaction is something which we need not worry specifically about. We would study the various effects of Endoxifen through various literature and through various aspects, and how we would take it forward is through a lot of clinical study trials. Phase 3 trials we'll look at. Initially it mentions the comparison with divalproex, and divalproex, again, the dosing which was there is 1 gram, which I'll come to why it is right and why it is not right. But it was perceived and it was inferred that Endoxifen is a non-inferior treatment option for bipolar patients, and also there was no major any side effects per se in terms of any fatalities or anything of that sort. We also saw that the other aspects about YMRS score, the subsets of YMRS score, those also benefited, and there was a significant improvement in all those aspects. Again, the response and the remission, this is very important. See, a patient with mania might sell off his flat within the next 10 to 15 days. So by the time he goes to the registration office, we need to stop him. So 7 days, there's a good response and a remission rate, and within 7 days, there is a very good response which is seen as compared to the divalproex group. So that needs to be kept in mind, that the response and the remission is much quicker. And also about the Montgomery-Asberger depression rating scale, there is a significant improvement, and also the clinical global impression scale, those things also have improvement. And this is all through various literature, primarily to Ahmed et al., the wonderful literature. And here we go about the various side effects. So we can see that we have the side effects enlisted, and the side effects may obviously range from gastritis, it can be headache, it can be insomnia, and it can be vomiting. The good thing is most of those side effects are mild to moderate, and those side effects doesn't happen for everyone. So it's not that every patient of Endoxifen gets these side effects. And also the most important aspect is all these side effects are manageable. If it's gastritis, we can give PPIs. If there is vomiting, on-dem is always there for us. Restlessness and insomnia, benzos are there for us. So as such, I have also seen a lot of psychiatrists prescribe Endoxifen with together with benzodiazepine anyway. So about the incidences from the Ahmed et al. Study, so we can specifically see that nausea and headache and insomnia are the parameters, and the study group were comprised of Endoxifen 4 mg, Endoxifen 8 mg, and divalproex, obviously 1 gram. And we also see that in these patients, when we checked, so the participants initially was 27, 28 and 28 respectively. And nausea, again the percentages, if you see, it's around 3% for 4 milligrams of endoxifen, 3% for the 8, and around 17% for divalproex. In terms of headache, again it's in the same order of 7, 10 and 10. So that's about this. And about insomnia, again the percentages respectively for those three groups are in a way that it is around 3%, around 7% and around 17%. And no deaths have been reported. That's a one good thing. And patients who have left the study because of adverse effects, it's only 2 patients, and that too in the 4 mg group. It's not that har koi decided to leave the study because of any side effects. Moving forward, the most important slide for today, important in the sense that I found this study to be very useful and very informative in that way, because I found that this is a systematic review and it encompasses many aspects of studies which have been done in the last many years. This was published in 2024, a study by Joseph Jitten et al. And various aspects. See, the good things about endoxifen are there. No one is disputing those things right now. Obviously, the thyroid abnormalities are not there. A lot of blood sugar elevations or any metabolic changes specifically are not there. So it is good in that way. But as a devil's advocate, I need to just think upon various other aspects which may be left out. And this study has done the work for me. So it has given me many points which I would like to highlight. One is about the dosing. So dosing, if you see most of the studies of endoxifen which is published in the last many years is about 8 mg. It's not about 4 mg. It's not about doses higher than that, 12, 16. The published data I'm speaking about. There are few, but not many. Second thing is about the maintenance aspect of it. Maintenance dosing, again, maintenance, there is not much studies available for maintenance in the sense, in terms of long term. There is one case report, I believe, of AIMS, in which 1 year endoxifen was continued. There is another study of 9 months, but beyond that I don't find any study specifically. So that is one thing which we need to keep in mind, that more studies are required for long term use of endoxifen. How does it work? How does it remain fine with the body? So those things. And some efficacy confounders, in the sense, see, endoxifen is good, no doubt about it, but then there can be some efficacy confounders, in the sense that if you see certain patients in the various published case reports had comorbid substance use. So it is possible in some patients that the substance was stopped and the substance induced mania also stopped. So that needs to be pondered, and that was well described in this systematic review. They also mentioned about other aspects, that some patients were also with concurrent medications of atypical antipsychotics or other mood stabilizers. So how much of it contributed? So that was also one more thing. And the most important thing, so we have been abusing divalproex, se acha hai. It might be good, I'm not saying it is not, but the one aspect about the various studies is that divalproex, so all of us know, according to Stahl et al., the dosing required for mania per se is around 20 to 30 mg per kg. So even if you take an individual who's maybe lesser in weight than me, so even that particular individual, if it is 60 kgs, then we would see that 60 kgs if you calculate, it's the dosing required is 1200 to 1800. So the comparison group has always been 1000. So that's a critical point which was mentioned. And about the various other side effects which we can think about. So overdose. I don't know how many of you have experienced overdosing in patients who have consumed multiple tablets. There is one case report on the fact that patients I think they had consumed around 7 tablets of endoxifen, which is published, and not any major side effects was noticed apart from vomiting, which was managed symptomatically. Just before coming here, I spoke to Dr. Sagar Karia sir as well, and he told me about a case which pertained to overdosing of 50 tablets, 8 mg each, so 400, and there was no major effect. So that's a good thing which was noticed. I also learned from that example on a lighter note that the patient must have been very wealthy to have 50 tablets at their disposal. But apart from that, there is also this aspect wherein we need to see that what are the theoretical side effects? So common side effects I've enlisted. There are some theoretical side effects which can be possible in literature according to tamoxifen. So tamoxifen again, so tamoxifen is the parent molecule. So we should not be judging, or we should not be criticizing the son for the sins of the father, right? So what are the theoretical side effects expected in endoxifen which people worry about? So endometrial carcinoma, very, very dangerous sounding disorder, unfortunately, and also about venous thromboembolism. So these are theoretical risks, but then it is not possible because the dose of endoxifen is at 8 mg, and generally the reports which have been published is at more than 160 mg in oncology patients. And the mechanism of action, if I have to go into the molecular level of how the molecule works in terms of tamoxifen and endoxifen, it's very much in detail, but just to give you an gist, the ER subunit of where the partial agonist and the antagonist works is differed in terms of tamoxifen and endoxifen. So those actions and the tumor suppressing effect of endoxifen is different. There is also other effects of ER alpha being antagonized more by endoxifen. So these are some of the molecular differences per se. And the other aspects which we can think about, the most elephant in the room, if I could say, ovarian cyst, which people have been talking about everywhere. What about ovarian cyst, and like what are the dangers or what are the concerns that female patients need to have? So there is not much literature obviously of endoxifen in psychiatry use having ovarian cysts, and the reason I say that is because even in people and even in patients whom we have seen, they have had predisposition to developing the cyst, maybe due to hormonal aspects, or maybe due to carcinomas themselves, or also maybe due to the fact that they have had other aspects, immobilization, or maybe factors which contribute to overall to the hormonal dysregulation as well. Those things needs to be studied. But then if you ask me what has to be done if a person develops, so there are some gynecological guidelines which I'll just run through, not specifically pertinent, but then the reason I want to run through that is because it is not that a person develops ovarian cyst and we need to immediately refer them to gynac and give them the cut that they require. So we need to first see the symptoms may be asymptomatic, it can be menorrhagia, it can be adnexal mass, or it can be other aspects like something the patient can be having a lot of pelvic pain which is radiating also. So in these patients we need to do an USG obviously, and if the size is less than 5 centimeters, then we just need to observe. We don't specifically have to do anything particularly, and once the observation part is done, we can repeat a USG in 2 months just to check on it. If the size is more than 5 centimeters, yes, we need to send them to gynac and do an hormonal review as well. And also if the patient has complicated cysts, then maybe Doppler or MRI is also indicated. And the complications of these cysts are very, very, very rare. We are talking about ovarian cysts themselves being not common in endoxifen psychiatry patients. So we are talking about complications in this minority. So it's very rare, but then things like ovarian torsion or ovarian rupture may require emergency surgeries. But then that's, as I mentioned, very rare. Also, the other aspects about Dr. Somil also wanted me to speak about special populations, and someone just spoke about the special population sometime back as well. So there is a case report published about renal and geriatric so it's a common thing. Basically the patient was old and also had renal dysfunction. So ek maar do tukda, matlab one case report solving two things. So in that way it was found that it was well tolerated. Some hyperammonemia and those things were there, because of which other medications could not be given, and it was well tolerated overall. In terms of the hepatic part, it is not specifically seen wherein hepatic toxicity has not happened, but then still LFT is advised according to some guidelines. Child, dearest Shoruk ma'am spoke very well, and but then the unfortunate part is there is no published data about bipolar specifically, and she also mentioned the reason, because we treat symptomatically basically in many of those populations, and neurodivergent populations case reports needs to be published more in terms of the endoxifen use. But in terms of bipolar, there isn't much of data. And pregnancy again, like it is not advised. So these are some of the special populations, and with that I would like to thank all of you for the patience and for the time. Thank you.